Welcome, everyone. I'm Dick Deming. I'm Medical Director of Mercy One Cancer Center and the founder of Above and Beyond Cancer. Welcome to our weekly cancer education series. It's brought to you in part by a grant from the Iowa Oncology Society. And our guest this evening is Dr. Justin Busick. Welcome, Justin.
Hi, Dr. Deming. Thanks for having me.
Thanks for being here. Justin is medical oncologist with Mercy Cancer and Blood, a division of the University of Iowa Healthcare. And he's an Iowa boy.
That is correct. Yeah.
He has been in practice here with Mission Cancer and Blood for about 2 years now.
A little less than that. Actually, not quite a year yet.
Not quite
coming
a year.
up on
Okay.
a year. Yep. Coming up on a
Good.
year this summer. So
Good.
it's been a little
And you're from Pella, Iowa, right?
I am, yes. Pella, born and raised. This will disappoint some people, but I'm not Dutch. My family is from other parts of the country originally, but I did grow up in Pella, and spent a good part of my young life there.
Okay. And which high school did you go to?
So I went to Pella High.
Okay.
Big rivalry with Pella Christian, so got to make that clear that it was Pella High. Yep.
So my favorite question, what is your personal claim to fame from high school?
That's a great question. I was pretty involved in a lot of things. I enjoyed music. I did sports, all of that stuff. But academics was number one, if you can, tell where I ended up. So I'd say my claim to fame was I did have the highest GPA in my class. We didn't have valedictorians, but I did.
Well, you would have been. Had they called it that? Valedictorian?
If they had it, so that would be it, I guess.
And did you in sports? Which sports did you compete in?
So I was a runner. I ran cross country, and then I also played tennis in the spring. So yeah.
And music.
Yep.
Okay.
I love to sing. Did that all through college as well. So now just for fun, but yeah, enjoyed that.
And then when you graduated from high school, where did you go to college?
So I went to Wartburg College in Waverly. Okay. So stuck around in Iowa.
And how did you choose Wartburg?
Yeah, that's a really good question. So I went back and forth on a couple different places, looked at the University of Iowa. I also explored some colleges in Ohio. I have some extended family there as well. And Wartburg just seemed like a college that was going to set me up for success, both knowing at the time that I was thinking I wanted to do something medically, and then just kind of the close-knit environment. It's a very small campus, very small university population-wise, and so that just kind of fit everything I was looking for.
And when you started college at Wartburg, what was your very first declared major?
It was biochemistry right from the start.
So you knew you were going to be pre-med.
Yes. Yep.
Okay.
I knew that early on.
Where did that come from? The desire to be a doctor?
Yeah. So I was always interested in science growing up, like even in elementary school. I loved space. I loved nature. So I was always really drawn to the sciences, and it was more kind of later on in high school that I really started to consider medicine as a career. And I wasn't set on being a doctor right from the start, but knew that something kind of in the medical field would appeal to me. I found anatomy really interesting. Even just learning the little bit of kind of pharmacology that we did, that was always interesting to me. So from just kind of academic and my own interests, that's where it kind of stemmed from. And then there was a personal piece to it as well. So just some experiences with different family members being involved with different areas of medicine. And that's really what ended up drawing me into oncology originally too. So kind of that intersection of both personal, but just interests from a young age.
And then when you were in college, I mean, things changed a lot from when I was in college, and you sort of just did your academic stuff and went on and applied to medical school. You probably got involved in doing some either shadowing or having some clinical experiences, even as a pre-med student.
Yeah. Yep. Absolutely. It was kind of happenstance too, with where I ended up now, but I also got involved in just kind of some basic science research early on too. And it happened to be with ovarian cancer. I wasn't necessarily seeking that out, but it was just again, very basic science project with ovarian cancer cells and looking at kind of cells, how they communicate and how cancer grows. And so got involved with that and was involved in those projects for a couple years of my undergrad experience. Did some shadowing as well. I met with some primary care providers in the area. I also volunteered at the health center in Waverly too, so got to see kind of all behind the scenes, but also come into contact with patients as well, so just from very early on, really.
And then you graduated from Wartburg,
Mhm.
and you went to.
So the University of North Dakota, which is where my dad grew up originally, so that was my connection there. But yeah, went even further north, even colder weather.
So up to Grand Forks.
Yes,
right?
correct.
Yeah.
Yep.
Yeah.
Yep.
And so did a little colder up there, but not that different.
Yeah,
what would you
it's the winters last longer. There's a little more snow, but yeah, I mean, it wasn't traumatic from growing up in Iowa for sure.
And the medical school experience you had was probably fairly conventional in terms of the first couple years, mostly classroom, and the second couple years clinical.
Yep. I think even more traditional than what some are moving to now. But yeah, I spent the first 2 years in the classroom, and then and they actually spread us out for clinical years. So I was in Fargo then for third and fourth year as well. So yeah.
When did the desire to become an oncologist creep into your mind?
Yeah, I would say pretty early on into medical school, I at least had some idea that that's what I was interested in. That stems back to earlier in life for sure. My dad's dad, my paternal grandfather, when I was kind of in middle school into early high school, or sorry, actually high school into college, he was diagnosed with lung cancer, and so saw that kind of experience firsthand as far as the impact it had on him, but also my family, seeing my dad and his sister go through what they did with my grandma. It definitely left kind of a lasting impact on me, particularly the relationship my grandfather had with his oncologist, and it's such a interesting relationship, but it was very, very powerful for my entire family, really. And so that left a lasting impression on me as I, got more and more interested and knew that I was planning to go to medical school. So I knew fairly early on that that's at least was in the back of my mind, and it just kind of progressed from there. Rotations that I did in med school reinforced it, and even going into internal medicine residency, the first rotation I did just happened to be the inpatient hemonc service at Iowa, and so and it just grew from there. I really grew to enjoy it.
And for those who don't know, it's a long path, because oncology is actually a fellowship. You have to first do internal medicine.
Correct.
And
yes.
for you, that was 3 years of
Yep,
internal
3 years
medicine,
of internal medicine.
and
Yep.
then you apply for the fellowship.
Correct.
And
yes.
did you do both internal medicine and your oncology at the University of Iowa?
Yeah, and I actually did an extra year of fellowship with palliative care and hospice as well. So yeah, so I had quite a few years of extended training, but yes, it was all done at Iowa. So.
And as you're doing internal medicine and then going into oncology at the University of Iowa, do you also have a research year where you do either bench research or clinical research as part of your fellowship?
Yeah, it's at least at Iowa, it's really incorporated into the training itself. So I didn't do just like 1 year specific of research like some institutions do, but yeah, they highly encouraged research in residency. And then once you were in fellowship as well, there was dedicated time. We got, months at a time to do research too. So
yeah. And I think you're fairly unique in terms of including palliative care and hospice as part of your overall training. So, it sounds like you did that consciously as part of your oncology, not that you wanted to do on palliative care or hospice separately, but that you wanted to incorporate that skill set into your oncology.
Yeah, absolutely. I mean, I knew just from some early experiences in residency, kind of the intersection that palliative care and oncology have a lot. Not that you don't, see patients with other diseases or illnesses, but there's just a huge overlap there in the needs. And so that became something that was really important to me. One of the things palliative care emphasizes is care for the patient that's not just physical, not just focused on the symptoms, but, mental, emotional, spiritual, whatever is important to someone. And so that's what I loved about it, was really getting to know the patient outside of just their physical diagnosis. And as you can imagine, it really was a valuable skill set.
It's huge. I don't even know where I first heard this, and so I repeat it a lot, but I don't attribute it to whoever initially wrote it. But a beautiful saying that not all patients can be cured, but every patient can be healed. And sort of the palliative care philosophy, regardless of whether you have a cancer that is, curable, there are so many things we can do that can be healing.
Absolutely. Yep. Yeah, I agree.
Where did your palliative care year fit in with your training with internal medicine and oncology? Did it was it sprinkled through, or did you do it before you went into the fellowship or after?
Yep. So it was kind of smack dab in the middle. So I did the 3 years of residency, did palliative care for a year, and then went on to oncology for 3 years. So
in the University of Iowa, lots of oncologists, and at university settings, the oncologists, when there's a lot of them, tend to then subspecialize. What was your experience going through your fellowship? Did you kind of rotate body system by body system, different types of cancers, or at what point did you have your own clinic that you were actually, as a fellow, taking care of patients? How did they organize your fellowship at the University of Iowa?
Yeah, so it was a lot like you said. We spent a fair amount of time rotating through the different subspecialties, different tumor types, seeing things like blood cancers, and then also some non-cancer blood issues too. So we got a whole breadth of experience, but it was a mixture of going to various subspecialty clinics. We also spent time in the hospital itself, doing consults on patients that were admitted for those different, answering questions that other primary teams had. Iowa also has a dedicated blood cancer service, and as well as bone marrow transplant. So we spent time doing that as well. And it's really mixed throughout kind of the 3 years. You do a little more of hospital in the first year, and then you do a lot more clinic as you're getting closer to, heading out in your own career in the later years. And so I had my first kind of official clinic in my second year. I was at the VA for that, the Veterans Hospital. And so over there, we really got our own dedicated clinic to see our own patients. It was our job to follow up on results, contact patients, really make decisions too. Obviously, you ran it by a staff, but that was kind of my first real experience to say, this is what I get to do someday.
So about 15% of cancer patients in the United States are treated at university cancer centers, but about 85% are treated at community cancer centers. You're now in community cancer centers. Did you have any training in your fellowship where you had outreach to community cancer centers as part of your fellowship?
Yeah, so not a lot initially. There is the opportunity for that. People could go to Des Moines, go to Cedar Rapids, or some of these more community-based programs. I ended up not doing that just with how my schedule worked out, but definitely talked to a lot of people who had been in community-based centers as I was going through my training and kind of getting a sense of what the differences were in that. There's also an affiliated clinic in the Quad Cities as well. So we're connected to those providers too, and kind of get that experience that they do more community-based practice. And so I felt like I had a good sense. One of the things that really drew me to community is I like a little mixture of everything. And so obviously it's great to subspecialize and be an expert in that, but I like the variety and seeing a little bit of everything throughout my day.
So now you're with Mission Cancer and Blood, and you're kind of headquartered here in Des Moines, Iowa, but Mission Cancer and Blood also has a clinic in Pella, your hometown.
It does.
And that's where you have a clinic.
Yes.
So what is that like, being back in your hometown as, little Justin Busick is now a medical oncologist, seeing probably teachers of yours and parents of friends of yours, and how has that felt?
Yeah, so I go to Pella once a week. It's honestly, I've told several people this, but it's surreal. Walking into the clinic, especially the first few times, it honestly didn't really feel real. Um, I tell this story, but I volunteered at the Pella Hospital, as a high school student. And so to have even had the inkling then that I would hopefully one day go to medical school, hopefully one day be a physician, it was just such like a full circle moment for that to really walk in. And so, yeah, I'm super appreciative. I loved growing up in Pella. I really feel like it had a long lasting impact on, who I became as an adult and who I became as a physician. And so, to be able to give back to the people in the town is really, really meaningful. So.
Mhm. So you have clinics here in Des Moines and in Pella,
Mhm.
and as you reminded me, it's not been even quite a year, so it takes a while to sort of, you know your medical stuff, but figuring out how to do the practice and fit all the pieces
Mhm.
together.
Yeah.
What has been the biggest change in terms of practicing at a comprehensive community cancer center versus a university cancer center?
Yeah. So I think one of the things is just, the resources that are available, you just have to get used to. They're a little bit different at a smaller institution, at a community-based center. I mean, we have a lot of resources here in Des Moines, which is wonderful, and obviously all the different groups that we're able to collaborate with, it helps provide some really excellent care. But it is just different than the academic center. Also, we're lucky enough here too to have access to clinical trials, but not to the same extent that you would at an academic institution. And so, that's really heavily emphasized, evaluating patients for trials. And we're trying to bring, more and more of that to Des Moines so that patients have access to that. But, and then I'd say just how your day is spent too. Again, I see a little bit of everything throughout the day, which I love, but it's just very different from the academic setting where you're kind of, back to back to back similar tumor types or hematology blood problems. So.
Um, do you have one of the things that I have enjoyed about being in a community like Des Moines or Pella is the opportunity for physicians not just to be taking care of patients, but to get engaged in the community. You've only been here a year, but to what extent do you see getting engaged in the community as part of your goal to be, a part of a community like Des Moines or
Yeah.
Pella?
Yeah, I mean, that's huge to me. Being from Iowa and growing up in Pella, I mean, I want to be a fixture in the community and be a part of it. I still think I'm trying to figure out the ways that will look, in the coming years. But I've been to some events already just through Mission and just being an oncologist in Des Moines, and so that's been wonderful. There's already, I think, a lot of effort to try and bring different educational things to providers here in Des Moines as well. And again, hoping to be more a part of those in the future. So that's it. I'm looking forward to that more, and we'll see as the years go on.
So let's talk a little bit about oncology. Obviously, there's probably never been a time in the existence of the world where things are coming at us just so quickly. As you know, I'm a radiation oncologist. We're really not inventing new types of radiation, so the changes in radiation are pretty slow
Sure.
compared to medical oncology, where I mean, every month there's new
hmm
drugs.
hmm
Number one, how do you keep up on all of the new changes that are happening in oncology?
Yeah, it's a really good question. I mean, it's a challenge. It's an exciting time in medical oncology because of exactly what you said. I mean, there's something new coming out every day. There's a new trial being published. There's a new targeted drug. So that part is really exciting because of the impact we're seeing, firsthand with how it's improving patients and their outcomes. But it is very challenging. And so my practice, and I kind of knew this, coming from the university, is I'm not going to be an expert in every individual tumor type. And so I think it's getting comfortable with that. And, it's something I'm still learning as I go. But, you just can't know everything anymore. It's tough. And so knowing kind of what my limits are, I try to keep up with kind of the big practice changing, publications that come out, and you do have to spend a fair amount of your time, reading and looking things up online. But just knowing what your limits are and knowing, hey, this is kind of the extent of my knowledge. So how can I get you connected to the person that will, know even more or have the
And
answer?
obviously, every single one of us have every piece of information in our pocket.
Mhm.
Do you have some favorite AI type of websites that you have found help promote your ability to keep up on things?
Yeah, one that I've used actually even more recently is Open Evidence. So I've actually found it's helpful in that it kind of directs you to the different sources, or kind of gives you, this is exactly this trial that was published. And so I've actually been using that a fair amount.
Yeah,
and
so have I.
Yeah,
And for those who don't know, I mean, it is a small language model in that it's just basically peer-reviewed medical literature. So,
Yep.
so it's not going to make anything up,
Right,
and it's
right.
going to tell us if there's not an answer. But boy, it's so much easier to just get the information quickly than just going through article after article.
Yep.
It really summarizes articles
It does very
well.
nicely. Yeah. If you were to just Google, trials for this tumor type, it'd be so overwhelming. So it does. Yeah, it kind of pieces it out into digestible chunks for sure.
So lots people think of medical oncology as chemotherapy, and and by some definition, it just means medicines. But obviously, there's so many different facets to medical oncology now. The old-fashioned chemotherapy that just kind of kills cells that are proliferating, the various forms of hormone therapy, and that's becoming pretty sophisticated in terms of breast cancer and prostate cancer. And then there's the targeted therapy and the immunotherapy, and then the stem cells, and then things that are kind of in between that are bispecifics. What give us a little bit of primer about, let's talk about bispecifics, for example.
Sure.
So that's a term that nobody was using 5 years ago, at least nobody that I knew.
Right.
And now we've even got shortened versions of talking about that. I think that is a form of treatment that is kind of confusing and most people don't know about. So I'm going to give you, the first time ever we're talking about that on this show.
Okay.
You are going to be the educator
Sure.
for what is bispecific therapy and how do you put it into the whole scheme of medical oncology?
Yeah, absolutely. So it's absolutely one of the most exciting kind of treatment advances in the last 5 to 10 years. They've been around in clinical trials for a little while, but they're becoming standard of care for, we have a lot of evidence for it in more of the blood cancers, but as we've then tried to use them more for solid tumors, we're finding more and more that there's a lot of hope and optimism that they'll be effective in those tumor types as well. And so so bispecifics, how I kind of explain them is they're kind of the parent that is going to drag the cancer cell and your immune system cell together, kind of force them into proximity when they don't want to be, and help your immune system then recognize that, hey, this is a cancer cell, this shouldn't be here, let's get rid of it. And so there's still IV treatments, infusions that you get, but they're a lot smarter than chemotherapy. So chemotherapy is kind of like whacking an ant with a giant mallet, where this is a lot more specific, a lot more targeted. So you're just trying to be much more targeted in your approach to treating the cancer. And so I think of it in that way. It's kind of the linker to pull these two cells together.
And then there's a related thing, CAR T therapy. So I'm going to try this out on you. So this is, I'm not a medical oncologist. This is how I explain to people about CAR T therapy. So you take your own, the patient's lymphocyte that knows how to kill a cancer cell. And you take it out of the body, and then you send it to California and teach it how in a test tube to fight its own cancer. It learns to be kind of like you send your your dog to school to find the cocaine in the
The drug dogs.
luggage, and then
Yeah.
you send it back. So
Yeah.
then you send the lymphoma back and you put it in the patient.
hmm
I mean, the lymphocyte, and it's now learned how to kill its own cancer cell.
Correct.
And
Yeah.
and that's the CAR T.
Yes, that is CAR
And
T
the
cell. Yeah.
bispecific is a little bit kind of like, but it's doing it within the body.
The body itself.
You don't
Yeah.
send it off to school.
Right.
You kind of use some drugs to bring the body's own lymphocyte, which has the ability to kill cancer cells, together with the cancer cell in the body.
Yes. Yep. Yep. The CAR T is kind of engineering the immune system to just be a smarter immune cell to really recognize the cancer. The bispecifics are kind of the bridge between the immune cells that are already there, just helping them more easily identify these are cancer cells. They shouldn't be here. So let's get
Do you
rid
think
of them.
bispecific will replace CAR T?
I think there's going to be uses for both, and there's so patients even that fail CAR T cell therapy can still be candidates for bispecific and vice versa. So I think there's uses for, but there will be situations where they can still both be used, and that's part of what some of the ongoing clinical trials are looking into is what is the right order of operations to use these things. And again, as we mentioned, it's an exciting time with all of these new tools that we have, but knowing exactly what's the right order to put them in and to use them for treatment, that's some of what we're still trying to sort out.
And CAR T and or bispecific will probably replace stem cell transplants in some diseases, maybe like myeloma.
Yeah, it's. I think that is definitely a direction that things could be heading. Is that transplant will continue to fall further out of favor. I mean, there will probably always be some role for it, but I think for some disease states, for sure, that these treatments are already kind of leapfrogging transplant and how effective they are, and the impact they have on the patient long term. So.
In the time that you have been in training in oncology and now the year out of training, what are you most excited about when it comes to novel cancer treatment?
Yeah, so I mean, I do think the bispecifics and CAR T cell therapy are really exciting, and what will be really interesting to see moving forward is just the more situations that they're used in, especially for solid tumors. I have a couple of patients right now with small cell lung cancer, which, if they didn't respond to chemotherapy, and even if they did, it was usually short-lived, prognosis was really, really poor. And so now there's a bispecific treatment that's approved, and we're seeing longer and longer responses than we ever used to, and even what I saw in fellowship. And so it's just dramatically changing the outcome for that patient. Outside of that, there's a lot of new targeted agents, and I do think this is the direction that oncology is heading, is that it's not going to be a one size fits all. We're going to get down to the nitty gritty of each individual's cancer type and what is the best targeted treatment that we can use for them. And there's still a long way to go for that. We can gain a lot of that information, but there's still situations where we don't have a treatment or we don't know what to do with that or how to target it. And so that'll, I think, be a lot of the research, as we move into the future. But yeah, again, there's always these new targets every day. And even from me starting fellowship to now, there's drugs that have come out that are available for these mutations that before we didn't know what to do with them. And now we have a treatment. So.
Yeah. And maybe give the audience a sense, like, let's talk about non-small cell lung cancer. So, not that many years ago, as you did a biopsy, the pathologist looked at it and it's a squamous cell, it's an adenocarcinoma, it's a large cell undifferentiated. And sort of the treatment was based on just what the pathologist saw under the microscope and how he described the size and shape, he or she described the size and shape of the cells.
Right.
Now, talk a little bit about what happens when we make a diagnosis of non-small cell lung cancer, the next step before you start treatment.
Yeah, so now really before you start any treatment, you will often send some what we call molecular testing, which will look at the cancer's DNA, just similar to human cell DNA, but it will look for what changes do we think kind of drove this cancer to form? Why did this cell become abnormal? And so again, more and more each day, we find mutations that we're able to develop targeted drugs for. And so, especially for non-small cell lung cancer, that's dramatically changed treatment, because these targeted therapies, these treatments that we have, are sometimes even way more effective than chemotherapy is.
Maybe describe a little bit about, what's the difference between a traditional chemotherapy for non-small cell cancer, and then maybe describe what a targeted therapy is, like for an EGFR and ALK mutated tumor.
Yeah, so when we think of traditional chemotherapy, and again, it depends a little bit on your definition, but you think of kind of the IV infusions that people come in to the clinic for. They can get really nauseous or really fatigued, not feel well, lose their hair, all of those things. When we talk more about these targeted agents, oftentimes they're actually oral medications that you take. So it's a pill that you're taking once or twice a day at home. There's still monitoring. There's still side effects, of course, as with anything. But some of them are a lot better tolerated than traditional chemotherapy is.
And they're actually kind of chemically engineered to affect a cell that has a particular characteristic.
Right. Yep. They're much smarter, much more targeted to that mutation, that cell that has that, rather than just kind of being toxic to everything like chemo.
So again, one of your unique aspects of your education was doing that year of palliative care and hospice. Mm-hmm. Maybe talk a little bit about how that philosophy of care, a cancer center has to focus on killing cancer cells, but it shouldn't be the only thing a cancer center focuses on.
Right.
It's got to focus on all of the various aspects of what it means to be a human being, and the physical, psychosocial, emotional, philosophical, spiritual. How does your year of a palliative care and hospice maybe change the way you might even approach the very first meeting you have with a patient? Mm-hmm. Patient's on your schedule. You're going to meet them for the first time. Most of the time when you and I meet a patient, they've already got the diagnosis of cancer.
Right.
Most of the time.
Right.
So you walk in and you know that behind the room is going to be someone who's been diagnosed with non-small cell lung cancer. Mm-hmm. What's your approach when you first walk in to meet the patient?
Yeah, I think it makes me much more cognizant of things even up front, to be thinking about beyond just the diagnosis and what treatment is going to look like. I'm kind of already thinking about what are the most common symptoms the patient might experience. How are we going to manage those? Looking at the rest of their medical history, is that going to put them at risk for certain things that I'm already trying to kind of anticipate and prepare for? I always try to ask patients as I'm talking to them about treatment, and keeping that in the back of my mind, what is the most important thing to them? What is their goal? Because it's not just what my goals are, it's what their goals are. What is the most important thing to them? Because it's different for everyone. Mm-hmm. Even if you had 10 patients with lung cancer, all of their goals are different. And so I try to, tease that out early on as I'm getting to know them, and tailor things. I'm still going to offer them treatment and standard treatment, but try to tailor things in a way that makes sense.
I'm just curious, how do you tease that out? What's your interviewing technique? How do you get to know a patient on that very first day? My experience is, if you invest time that very first day, it really sets the stage for your whole relationship. That might be a 10-year relationship with the patient.
Right. Yeah. I think mine, my approach is to be try to give them the time that they need, just be very open-ended, let them kind of lead the conversation a little bit as well. Try not to ask too many detailed questions. I really try to give them the space to tell me who they are and tell me, again, those important things to them, whether it's, these family events or, things that they're looking forward to in the future, and really get a sense of that. Because again, I think it does help guide you in how treatment might go, and how you can help them, just anticipating that.
So for me, when I'm going into the patient, one of the distinctions, and sometimes it's shades of gray, but for most situations it's not, is like, okay, is this potentially curable, or is this a living with cancer forever sort of situation.
Yeah.
I mean, miracles happen, but we kind of have a good idea. Is that something that is part of the conversation?
Yeah, it is. And I obviously I only know my experience, but I do wonder if some of that just stems from my palliative background, because that was, something that was very emphasized, is to make sure it's clear kind of what the goal of this treatment is, or what this is all being done for. And so I do try to be very upfront with patients in that regard. And, like you said, sometimes it's a little bit harder these days, because even tumor types that we thought were not going to be curable, we're seeing these more durable, longer lasting responses. So I always try to be as honest with them as I can. Like, these are the goals, or this is what I see the treatment doing for you. And so how can we, formulate the plan moving forward to reach whatever those goals you have, and again, what's most important to you.
As you see your future playing out here, you're part of a very big and very experienced group. Do you think your group will end up subspecializing a bit more, or traditionally, as we talked about, in community settings, most oncologists kind of do everything, although sometimes, depending which tumor boards you go to and what your expertise is, you sort of become the go-to person for certain things. How do you see that playing out as the treatments for the various cancers become so very specialized?
Yeah, I think that's a good question, and the short answer is I don't really know how it'll play out. But you're right. I think everybody kind of has their niche, and there's already people that if I have a particular patient that I know, they're pretty interested in that tumor type, or the blood cancer type, that I'll go to them if I have a question, and they're usually always happy to help. But so I don't know. I think, again, a lot of us go into community oncology because we like the variety of things, but obviously everybody has their individual interests too. And so I'm not entirely sure how that will look moving forward, but at least personally, I hope to still be able to see a variety moving forward.
I think we're going to open up for some questions here. So we have a live studio audience. They'll get first questions for you. But if you are watching us live streaming right now, you also have the opportunity to ask Dr. Busey questions. So we can have you put the questions into the comment section of the software that you're using right now. Kevin, you get first question.
Yes, I think of the population of newly diagnosed, cancer patients as an army of amateur researchers. I mean, and they're looking all over for, try to find something about what's happening. And most of them are going down rabbit holes, maybe dead ends. Do you ever find anything, a door that's opened up by the amateur researchers?
It's challenging, and I'm always very open when patients approach me with things that they've read online, or if they find resources that they're wondering about. I try to be very open and receptive to at least hearing what they have to say. And again, I can't know every single detail, so sometimes there may be a trial that I'm not fully aware of. But so far I think I'm early on enough that I haven't found someone come to me and say, oh, I found this and it's changed things completely. But I also encourage people to take some ownership of their diagnosis, and looking into treatment options, and what getting their opinion on what they think is best for them. I will always take that into account. So you just always have to have the caution of not everything you read online is true. And so as long as you're taking it with a grain of salt, I encourage people to look into it some on their own.
So here's one, Justin. So just driving here for this interview on NPR is reporting on the New England Journal of Medicine article on the new drug for pancreas cancer, a positive clinical trial. And so the government's going to open up that drug to more patients even before it goes through full validation. So that's just on the news today, right? So that could affect a patient you see even tomorrow, right?
Yeah, yeah, absolutely.
Yeah.
Yeah, that's how quickly things change. So
Yeah.
that's,
Yeah.
you can see where it'd be challenging to
So,
keep
I
up
mean,
with
that
all
one would be, I heard that too. Let's look into it. And you know what? We probably couldn't have gotten that for you last week, but it looks like the FDA is going to clear the way, and that's a drug that we might get. Now, you probably have experienced this, and I have too, and I'm just curious how you answer this with respect and compassion. Doctor, should I be taking ivermectin
Mm-hmm.
for my cancer?
Yeah, it does come up some. And again, I always respect people bringing me information and what they've read or looked into. And, I try to come at it or with the approach that, I'm trained in a certain type of medicine, in a certain type of kind of scientific evidence. And that's what I know. And that's what I have to go based on. And so, I'm open to people doing things that I don't think is going to be overtly harmful to them. And so that's just kind of the compromise that I have to find with people in that.
So whenever I'm seeing patients, I'm always in a room with a great big screen. And I said, well, let's look at that. So we just go to clinicaltrials.gov and we put in their type of cancer and we put in ivermectin and we look at the clinical trials and we see, there are some clinical trials, but you know what? Right now, your cancer doesn't seem to there's anything that ivermectin's going to work for, and sort of validate that ivermectin is being investigated, but that right now there's no data that would suggest it's going to help you in your cancer.
Right. Yep. Absolutely. Yeah. I think a lot of what's out there too is, again, it's kind of taking it with a grain of salt. Like there's a lot of resources that it sounds really good. But when you kind of get into the nitty gritty details of it, it's a very different situation than what you're talking about with, like a human being and the dosages being used and that kind of thing. So yeah, it's all very nuanced.
So in your experience of a year here in Des Moines, what has been some of the most gratifying and professionally rewarding experiences that you've had so far?
Yeah, it's each day I just come home grateful that I get to do this job. And you talk to a lot of people that do medicine or do oncology, and it's those stories that you hear from patients that, they either went to this event that they were worried they weren't going to be able to, or, they got through the treatment and it was a really kind of scary time initially, but obviously they're optimistic and they're hopeful, and walking them through each step of that is just so rewarding. Getting to be the source of kind of comfort for them. Sometimes they're there and they don't have family members with them, or the family members, don't understand. And not that I understand what they're going through, but it's just to see them through each step in that process is so rewarding with all of it. But and I just, I've had patients say thank you, which it's simple, but it just is, it's really meaningful. You're obviously having an impact on their lives, and that's pretty cool. I mean, it's not something you can say with every job. So I'm loving it.
So I would imagine you've already had the opportunity to see patients successfully through completion of treatment to the cancer-free status and now just surveillance.
Yeah.
Have you also had the opportunity to utilize your palliative care and hospice and be able to help patients through a peaceful death?
Mm-hmm. Absolutely. Yep. Yeah, I've seen, both sides of that coin already several times. And one thing I do feel that the training that I received in palliative care and hospice gives me a little more perspective on too, is just kind of when is the right time to have those conversations and consider making that transition. And there's been some situations where it's been kind of right from the start that the cancer is bad enough that I just really don't know that treatment is going to even help you. And I worry that it's going to harm you. And so I've had those conversations as well.
Mm-hmm. And as you know, and you can bring on the palliative care even as you're starting off on a course of anti-cancer treatment, but have the palliative care there and,
absolutely.
and allows that flexibility as you move forward.
Right. Yep.
Other questions? George, do we have any questions from our live streaming audience?
Well, we've got a George question, and this is something we've dealt with on the show before. A newly diagnosed cancer patient, they're lot of times they're in a state of shock. They don't know what they want to do. They want to do something immediately.
Mhm.
What do you advise newly diagnosed cancer patients? What should they do? How do they choose where to go, and when do they go? What's the checklist?
Yeah, I mean, each situation is a little bit unique. And obviously as the medical oncologist, I'll try to give some guidance on that too. But I think that, the big thing is take the time that you need to make some of those decisions, because yes, there's some urgency to it, but there's also, I never want people to feel like rushed or pressured into a decision. And these are huge life-changing diagnoses that they're dealing with. And so giving yourself the time, I always encourage people to talk about it with family members. I just think that the more you have those conversations with the people that you love and care about, and obviously I'm happy to help give guidance too, but I think that it's important to take the time and really feel like you're getting all the information you need to make the best decision for you.
Another question I had, I move around in sports circles a little bit. It's kind of like classical music. If you talk to somebody that's into classical music, Bach,
Mhm.
they want to talk about Bach. You talk to somebody about new wave, cutting edge cancer treatments, they want to talk about stem cells.
Mhm.
And is that a realistic hope? Is that the future? Or I heard you talk a little bit about stem cells. Or are you moving away from that? I mean, I've heard people talk, you might want to leave the country to get stem cell therapy.
Mm-hmm.
That's where it's at. That's what some people believe.
Mm-hmm. Yeah, I mean, stem cells, we've actually used them to treat certain cancers for, decades now. But I think some of what that's referring to is actually more engineering the body's cells. And that's a lot of what we are doing with some of these treatments, like the CAR T cell therapy that Dr. Deming and I were talking about. They're not stem cells, but they are kind of genetically engineered smarter cells. And so I see kind of the future of cancer treatment, again, moving towards that very, targeted approach, kind of individualized treatment. And I think as we get better with the science, we get better with the study, as we know more about how to take these changes that we know about and make treatments targeted towards that, I think is really the direction that things will be going.
Yeah. And George, just a little bit on that. Some of the I think what you're referring to is using stem cells, not in necessarily cancer, but to try to generate new tissue, whether it's your knees, your spinal cord, your things like that. Because in some ways, stem cell transplant is a little bit like old-fashioned. It's basically chemotherapy that would kill the patient if you didn't give them the stem cells to survive the chemo.
Right.
So in some ways, stem cell transplants relies more on old-fashioned chemo than it does on the more targeted types of treatments that we're dealing with now. And the stem cells is just to allow you to survive the chemo.
To make it through. Yeah. Yep. Absolutely.
Yeah. Yes.
Is it on?
Yeah.
Thank you so much. This has been really interesting. I'm fascinated by clinical trials. And so I want to get a sense from you for how many patients, just on average, accept, if they do qualify for a trial. But I'm also curious, do you scan every patient for trials, or how do you find out about them? I know there's lots of them. So just a little bit more about that process, because I think it's really cool, but I don't know a lot.
And maybe even start at the beginning. What is a clinical trial? And why do we do clinical trials?
Yeah. So talking broadly, a clinical trial, how I'd explain it is we're looking for, is there something better? And it's not always treatment. There are clinical trials that look at other supportive care things that we can do to help treatment be more tolerable, or surveillance things with imaging that we do things in a different way. And so, but a lot of the kind of classic clinical trials that you think about, we're looking to see, is there a better treatment out there? And is there a treatment that we know of? Should that move closer to the front of the line when we're deciding, what is the best order for treatment? And so, I think when you talk about how many patients are open to it or interested in clinical trials, I think there's a fair number. I mean, I'd say a majority of patients that I bring it up to are at the very least interested. Some people have the perception that it's like a really experimental treatment, but even, early clinical trials have gone through years of kind of what we call preclinical, meaning basic science investigation, making sure this drug is safe and trying to figure out what's the appropriate dosing, all of that. So yeah, I'd say a lot of them are open to it. And how I try to phrase it to them is that this is opening up another potential avenue for you. And sometimes it's when there's no real other treatment options, at least that are standard. And so if they're still interested in pursuing treatment, but sometimes it's in a place where there are other standard treatments, but we're looking, is there something better? And is there something better for you? And so the answer, at that time with a trial is we don't know, but there's that potential that it could be. And so you're opening up that opportunity for patients.
Yeah, I think having clinical trials available really says that this center is willing to invest in, the time and effort, because it always takes longer to take a patient through treatment in a clinical trial than a conventional, already approved treatment.
Yes.
It takes longer to explain it, to consent the patient, so that they know that we don't know that this trial, that this version of treatment is going to be better than the standard. We have suspicion that it will be, but in order to determine which is the best treatment moving forward, you'll get randomized to either the standard treatment or this new treatment that we think may be better. But it really does is some courage on the part of the patient.
Absolutely.
Sometimes I'm sure you'll have experienced if they've gone through several and there's not a lot of other treatments left, then a clinical trial looks like, we've got something to do. But right at the very beginning, before you've had any treatment, and we've got a treatment that we're pretty sure has 80% effectiveness, and with this treatment we think might be better, it's a little bit of, do you go with the devil you know, or the devil you don't?
Tried and trusted.
And occasionally patients will go, well, gosh, I don't want to be a guinea pig.
Yep. I hear that.
So you hear that a bit, but once they hear the safety measures that it's gone through and the amount of research that has happened before you even get to the point of being able to offer it, most of them are pretty excited that they're in a center that they have that as a possibility,
as an option. Yeah, absolutely. And it, oftentimes it's, there's still those standard treatments available. So if it doesn't work how we hope, there's still the potential that they'll receive, these other treatments that we know are effective as well. And so that's how I always phrase it, is it's just kind of opening up another opportunity for you in your treatment.
Other questions from the live studio audience or the... Okay. Well, I think we're going to wrap it up. Dr. Justin Busick has been our guest. Justin is medical oncologist with Mission Cancer and Blood, a division of the University of Iowa Healthcare. He's an Iowa native, and we've got him back here in central Iowa. And it's just great to have you on our team and to be sharing patients with you.
Absolutely. No, I appreciate it. Thanks so much for having me, Dr. Deming.
And if you know someone that would benefit by watching this program, it's going to be available on demand beginning tomorrow at the Above and Beyond Cancer YouTube channel, and also the Mercy Cancer Center website. I hope you'll join us again next week. Thanks, everyone.